Slide, please.
Please,
Slide,
slide.
please. So, a very good morning to all of you. So, I'll be presenting management of ocular surface inflammation prior to cataract surgery. I have no financial interest. So, cataract surgery becomes the lips and bound, and the surgeons of the day are confident enough to handle the rocky brown cataract to white cataract. But Indians become the more in the refractive surgery. A favorable surgical outcome depends on the acute keratometry, axial length, lens thickness, and the anterochamber depth measurement, as well as the generation of the intraocular lens and formulation to determine the corneal and the correct impact implantation. So cataract surgery become the more of a the refractive surgery than is only the cataract surgery. The demands of the patient is not only the quantity of the vision, but the quality of the vision. So what's happened if the patient come like this condition, like the ocular surface inflamed eye with the AGM toxicity like this or the MGD like this? Will you go for the surgery? Or the patient having the diagnosed case of RA with the ADD or like this surface inflamed by the AGM toxicity or following this eye? So the smart answer behind what exactly the problem with this patient, why this it is not amenable by the previous medical management, and when should he call this patient for the cataract surgery? The smart answer behind these things, we should know the ocular surface disease, understanding proper, and the fecal emulsification on that special challenging scenario. So what is OSD? The ocular surface disease is highly prevalent in general population and can often have profound negative impact on the quality of the life of those who is affected. The incidence of the OSD rise in age and depending on its definition can range from 5 to 30% of the patients in general population. In patients with the glaucoma undergoing the medical treatment, it has been found additional risk are there, and it has been found that they have the 50% are undiagnosed having the OSD and having the patient with the symptoms 78%. So we should be know the what is OSD and when call for this patient for the surgery. So it's a big term and it's like an umbrella. It have consist of the dry eye disease, eyelid disease, conjunctivitis, keratitis, and multifactorial disorder of the cornea and the conjunctival epithelium, the lacrimal and the meibomian glands. As a whole, if your surface the road is smooth, your entire whole journey will be the uneventful. The underlying mechanism of the OSD typically results in either insufficient or aberrant tear production or increased tear evaporation, leading to the ocular surface damage and discomfort and decreased visual acuity, quality of the vision, and principally through the activation of various inflammatory pathways. So it's maybe the use. If we cut short the things simply for the recall, we can make it. We should encounter the following disease: the dry eye disease, the eyelids, the conjunctival even pathology is there, cornea or surface epithelium, or any inflammation, immune gland dysfunction, or is there any aqueous deficient disorder is there or not. And this chart is very much important because always there is a this chart is mimic the things that if the inflammation is going on, you have to break that circle. Otherwise, the things are going on, and you will be landed with the unhappy post-phaco patients. So, what are the signs and symptoms of the OSD? The stinging or the burning sensation, blurring of the vision, and the scratchy or greater film and streaks of mucus or red or inflamed eyes. So, all the red or inflamed eye always looked properly before going ahead in any cataract surgery. So, what is OSD? The OSD may be immunological or non-immunological. The common immunological condition associated with the ocular surface disorder, we should inquire further when we suspect the patient having the OSD. The SJS, the peripheral keratitis or POK, the Moran's ulcer, the ocular cicatricial pemphigoid, or the vernal keratoconjunctivitis, or it may be the non-immune like that's chemical injury sequelae, the limbal stem cell deficiency, maybe gland dysfunction, and blepharitis, or maybe the blepharokeratoconjunctivitis, will be cases sequelae, or degenerative lesion like the corneal, such as the Salzman nodular degeneration, or pterygia, or spheroidal degeneration. And it has been found that reported that Gupta et al. That at least almost 80% of the patient was undiagnosed of the OSD while they are undergoing the cataract surgery. Among them, 40% them had at least two abnormal tear tests is there. So why to rule out the OSD? The ocular surface changes and the superficial punctal keratopathy worsen the post-phacoemulsification and the post-euro cataract patients. Thus, cataract surgery can worsen the symptoms and signs if it was undiagnosed before the cataract surgery of the and the prevalence of the OSD those undergoing this cataract surgery reported to literature so far show that it approximately range from the 9 to 100%. So, and the patient may be symptomatic for almost 6 months after the surgery. So thus it is important to understand the nuances of the planning for the execution of the cataract surgery and patient with the pre-existing OSD. So three things we should be highlighted: the pre-operative planning, we should go for the surgery, why should take care, and intraoperative modification, and the postoperative outcome related to the cataract surgery, eyes with the OSD. And pre-operative evaluation, whenever we have to be in busy schedule, we should sometimes we miss the patient OSD. There on very quick thing is that when you are planning for the AT for this patient, just quickly look whether the patient, what is the, this patient come for the cataract surgery who is the father of a medical representative having the anti-glaucoma medication. We simply do the fluorescence staining and got there's lots of surface inflammation and the TVT was 2 and he was on 2 AGM. So we deferred the procedure, we just give the appropriate management and the plan do the surgery once the surface become quiet. So the fluorescent staining is one of the very basic thing but is important and to rule out the further sequelae. The fluorescent, this is the one of the patient why fluorescent staining is important. These are all these patient we are doing for the AT and just cross check the thing whether the surface is inflamed or not. So all most of the first two pictures showing this thing the patient under the AGM and once that at proper anti-glaucoma medications is given and we switch over the other preservative free AGM and landed up with a quiet surface. So objective test for the assessment, you have to be look at the leads and the lip view. If you have the thing, simply the Sharma 2 lead adnexion and corneal findings. So if the patient like this condition, we have to be just more precautious for go ahead the surgery before prior to the surgery. Specifically look for the adnexion if the MGD is there, proper address these things. If needed, the patient have the anti-glaucoma medication, address anti-glaucoma medication and change the formulation. Sometimes we'll stop all the anti-glaucoma medication, put the patient simply loteprednol drop for the couple of very slow rapid tapering and lots of lubrication as given to reduce the surface inflammation. And if the additional MGD is there, we do the course of the doxycycline 100 milligram 2 times for the 14 days followed by 1 month and evaluate the patient after 2 weeks and if the surface is white, we go ahead the surgery. And these are the very quick, revise for the OPD process. Whenever the patient come with the cataract surgery, suspected OSD is there, we simply go for the quick questionnaires and the risk factor assessment. If they rule out a systemic disorder, if any collagenovascular disease is there or not, and easily diagnostic tools, simply do the TR meniscus site while doing the AT. If it is suspected that AT surface that TR meniscus is reduced, or you can go ahead with the then further details of the meniscus examination and the staining pattern and rule out any underlying MGD or ADD is there or not and address this condition prior to the surgery. And if this patient having the aqueous deficiency, we address this patient and rule out the systemic collagenovascular disorder. If it is MGD or evaporative one, address these things with the proper management, lead hygienes along with the measurement of the both MGD and ADD. Now, what is the dry eye disease management involved? What are the rules for, and what should do for this patient? So, management of dry eye disease are involved the various strategies and therapeutic approaches in it to minimize the appropriate and evaporative tear loss, stabilize the tear film, protect the ocular surface, repair the ocular surface damage, increase the lubrication, enhance the glandular secretion, and cure the inflammation. And as a whole, we have to restore the surface homeostasis and keep the eye moist, quiet eye, and non-inflamed eye. And it has been guided by the use. What are the best thing? You have start the thing simply the preservative-free carboxymethylcellulose. Start with the things. Very simply thing is available, but and along with that additional treatment should be given. And role of artificial aim of the management dry eye disease is to address the tear film instability. What are the ocular surface disorder management? Highly we should be treat the thing if the tear is hyperostomal tear, we address the hyperostomal tear, and we have to give some of the tear substitute. We can long term adhere to the surface like sodium hyaluronate containing tear substitute. Risk increase the viscosity and reduce the inflammation, surface inflammation in the from topical your anti-inflammatory medication. If the you are dealing with the your RA patient or collagen vascular disease patient, or your if the patient with the under diagnosis of secretory conjunctivitis or the patient Moran's one, that patient has to be given the system immunosuppression in the form of microfilm fetal or IVMP before addressing the patient for the cataract surgery and reduce the surface inflammation. Now, why it is important surface biometry in calculation? I will power calculation on the ocular surface disease. Since the cornea account for the 2/3 of the refractive power, the keratometric value is subject to changes in the relative to the corneal curvature. The epithelial basement memory dystrophy and the Sageman nodular dystrophy. It has been found that we don't correct this ocular surface disorder, it will add the additional hyperopic shift of the patient. and thus any pterygia if it is more than 2.5 millimeter excludes the cornea, or there's a systemic symptomatic curvature or the stigmatism in higher order, then we have to be addressed this thing prior to the cataract surgery, and then better to wait for at least 4 to 6 weeks prior to the surgery. And which K reading we should take. In scarred cornea, the average the keratometry reading, if the central cornea is compact, we should take the manual keratometry reading. And why it is important? Because I'm just sharing one of the patient who came to us with this condition, with the surface inflamed, and we do the simply try to do this patient for the keratometry. This you can see the staining pattern. Then we abandon the procedure, give the patient sodium halonate containing the tear substitute along with the MGD management. And you can see that in the first picture, the K reading, this is the patient of Myers, where Myers was very much distorted. After 2 weeks, the same patient have the significant mind. So that is you will get the your erroneous result. So better to we don't jump for the cataract surgery for those patients who have showing symptomatic signs of the OSD is there. Wait for a couple of weeks and go ahead to surgery for this patient. The same thing here also, it's showing this patient with the epithelial basement membrane dystrophy or the dry eye disease, how the mass changes preoperatively and postoperatively. Now they come to the point which biometric formulation. The IOL Master 700 can also be provided reliable biometric value in eyes with the OSD, though the Barrett Universal 2 can be used for the mild to moderate tear film instability. If the IOL formula based on artificial intelligence AI algorithm such as Hill-Riff, BRF or Kane formula are more reliable in this scenario. If the gross K reading is gross damage, in that scenario we can take the axial ultrasonic of that eye or standard K1, K2 reading for 45, or we can take the K reading from the other eye, and that will give the appropriate measurement if the K reading grossly your damage. Now the question is that whether go for the toric or not. The toricity of the eye OSD can be dynamic and the progressive changes in ocular surface. So before the planning for the toric, eye should be quiet and there should be stabilization of the cylinder should be there. If you specifically consider toric, I will planning for the patient with the pterygium. Premium or multifocal? Yes, we can, but premium I will like the multifocal should also be avoided if the patient having the some of the progressive autoimmune disorder is there. Better to use the monofocal lens, specifically in the Murens or the your OCP patients are there. In case where the intraoperative viability of become the challenges and the status of the post-operative capsular cannot be clearly visualized in the scarred corner, it is better to use the 3-piece multi-piece IOL all this patient and abandon the premier multifocal IOLs. So preoperative ocular optimization of the ocular surface and before the cataract surgery. So what should we keep in mind when the patient having the OSD? The eye should be moist, there should be no surface inflammation, correct tear film instability, IOP should be controlled, sound posterior segment, appropriate IOL power calculation, rational surgical plan with minimum tissue handling. A team approach is don't hesitate to send your glaucoma or VR colleague when you have some of the issues with the AGM related toxicity. Sometimes patient need to be AGV when the patient is not amenable by any either of the any anti-glaucoma topical medications. And intraoperative modification for the facilitated surgery. Now, what is the topical anesthesia, local anesthesia? If the patient having the LA, the OSD is there, the local anesthesia better because the itself patient, the topical anesthesia can causes the surface inflammation during the and your intraoperative vision also be reduced. Phaco or SIS, definitely clear cornea phaco is much is preferable. If the grossly corneal visibility is poor, then that case ECC or the SSS can be tried. Clear corneal conjunctival cutting and definitely clear corneal incision much better for the neurosensory compactness and the your compactness of the corneal surface. Surface irrigation with the BSS or surface of coating with the OVD, definitely surface coating OVD during the procedure much more acceptable. And this ratio, the RP Center and the Namrata ma'am have one of the article published in IGO list. It's really, and I requesting all of you go through this. It's very wonderful article. Even I these things. So I am just concluding the things. So you do the ECC or SIC of echo. Definitely the clear corner of echo is much acceptable. These are the some of the relevant study. I'm just ending my slide. Some of the video presenting here. The first, this is a Morens patient. We have done the surgery after 3 months of quiet under the IVMP on the day of the surgery, and patient was under a microfilm offitil, and literally superior. Don't try to make any tunnel or these things where the gutter is the patient having the gutter is there. Little I was sitting inferior temporal part, and the visibility is really poor, and do the surgery. And here, if you the During the surgery, you can use the rectal illumination with increased good visibility of the things, or you can use the endo illuminator, which is used in VR surgery. And never hesitate to put a suture once you think the cornea dealing with thin cornea. This patient had a 6 by post op 6 by 9 vision with zero cylinder, and the surgery is completed. I put a suture and I switch on to the again the rectal illumination mode during the surgery. This is another patient, same thing, the post your SJS patient. During the surgery, we does same thing, rectal illumination mode. So this is the post-op of that Moran patient having the 6 by 9 vision, and these things. So yes, sir. So what is the last? This is the AI-based treatment modules. It's upcoming, and it's the best. These are the relevant studies. So conclusion, this thing, though it's quite challenging to operate the eyes with the severe OSD, salvaging the visual potential is providing this patient with best possible visual rehabilitation is also be important. The timing of the cataract surgery is very crucial to optimize the outcome for the cataract surgery and avoid the complication in this patient. It is also important to identify the manage the pathology of the OSD and address this condition whatever that is, and thus a stepwise and the holistic management of all the factors affecting the visual acuity and the quality of the vision should require this of this OSD patient. Thank you very much. Thanks for your patient sharing. Thanks, my mentors.
Thank you. Thank you, Dr.
Thank you.
Sarkar. The only question when you talk about cataract surgery in an inflammation, so how you control an inflammation?
Sir, we first of all
You
don't
have
do
so
any.
many anti-inflammatory drugs now.
First of all, we don't do any inflamed eye cataract surgery. The surface should be controlled. Then, in this aspect, if the patient having the some of the diagnosed case of collagen vascular disease, and definitely we have to address the topical medication as well as the systemic medication. Usually, give the very low dose of topical lotiprandol drop, and if the patient having the multiple AGM medication, we rule out the AGM toxicity. And if the patient with collagen vascular disease is there, that has to be and taken care by the systemic your immunosuppression, specifically on the day of the surgery. Once the even also eye is quiet after 3 months when touching the eye, I do prefer the 500 milligram IVMP on the day of surgery, and prior to the oral steroid 7 dose prior to the surgery, along with the well management of the your immunosuppression in the form of microfilm mofetil.
Thank you.
Thank you, sir.
Dr. Namrata, a question for you, because nowadays you get a lot of dry eye patients which are inflammatory dry eye. What you prefer as a pre-op medication that you control an inflammatory dry eye and then you do a cataract surgery?
For all inflammations, it is best to start topical cyclosporin, which we generally like to start. We generally like to start 3 to 4 weeks before the cataract surgery, and then continue also in the post-operative period for at least 2 to 3 months, along with the lubricants.
Okay.
Thank you.
Thank you.
Thank you.